Hello, everyone. Welcome to our channel. If you guys are new here, hi, my name is Jenny. I'm a family medicine physician and a mom of two. I recently graduated residency in 2020. And so today I wanted to talk to you guys all about the tips and tricks that I've picked up along the way, my personal survival guide, ranging from resources to how to deal with mean attendings, what to do when you're dealing with loss, and a bunch of other things. And I think this is a perfect resource for those starting intern year, but also for those who are starting medical school, starting into clinical rotations, or even people like auditioning and like shadowing med students. These are all great things for you to be able to, put up in your repertoire. All right, so go ahead and comment in the sidebar. I'll try to answer those questions at the end. Let me know if you guys can hear me. Give me a thumbs up or something like that so I can see and engage with you. We're on StreamYard, so this is like the first time I'm doing it, so bear with me. I'm going to share my screen really quick so you can see a little bit of overview of what I want to talk about. All right. So here, as you can see, this is just my Notion. We're going to talk about resources, mindset, dealing with failure, dealing with loss, dealing with mean attendings, incorporating more OMT into your practice if that's your thing. And basically any other questions that you might have in that sidebar or, description, just leave them in the comments. All right. So let's just jump into, I want to say though, that as an intern, no matter what rotation sorry, I'm like all flustered right now. So as a reminder for everybody starting intern year, no matter what subspecialty you're in, no matter if it is, say, dermatology, OBGYN, radiology, surgery, all those things have to take a couple months at least of medicine. Even psychiatry, they do medicine rotations their first year. And what that means is that they will be taking care of inpatient patients, people in the hospital, because everything in the body is connected. You can't be a surgeon and take out an organ in somebody's body and not understand like how the other organ systems respond, and say like something bad does happen, how do you manage that patient, or like how do you prep that patient going into surgery? So all these things are super important to understand, and so these are some of the resources that will help you be successful. So this is for everybody. Okay, so let's jump into resources. I would say the best book that I've used for inpatient medicine is called the Massachusetts Pocket Medicine Handbook. And I'll show you what it looks like. One second. I'm going to share my screen again. And I found this on Amazon. This one's $28, and then this one down here is $53. I'm not sure what the difference is. I would just buy the cheaper one if you wanted to. The reason why this is so good is that it has all the different possible things that you will encounter on an inpatient basis, and it teaches you all the things that you need to do, all the lab orders that you would need to go through. So see, here's chest pain, and it talks about all these different things. It's a good reference material. Not only that, you can also like put in your own notes in here. Pro tip though, if you want to check with your residency first, a lot of residents will leave their resources behind, like say the pocket medicine. Once you understand like the whole process and are more secure about your own medical knowledge, you don't need to reference the book as much. And so I say I used it intern year, but I did not need to use it as much the following years. And so I left my medicine book for the new incoming residents. So always check with your attending and see if, or check with your residency to see if they have any extra resources for you. Okay, and then this book I actually have. The radiologist recommended this book to me, and this, I highly recommend looking over all your chest x-rays, imaging studies, anything that you order about your patient. Always look at the images. No matter what the radiologist says in the write-up, like look at the images yourself. And so this book really helps you with, like, you know, learning how to read chest x-rays, learning how to read CT scans. This not only helps you in the inpatient basis, but also if you're doing emergency medicine. Highly recommend this book. Another thing is this book. I'm really bad at rashes. Sometimes they all look the same, and I'm just like, okay, we either try a steroid or antifungal. Let's see what we do. So this book, you probably got it in med school, but it shows like all the different pathologies. My only comment is that it's only on white people's skin. So people with pigmented skin, there's really no examples. There are other books out there that have, you know, other resources. What I used during residency, and I don't have the subscription anymore because it was only during my residency. I was part of U Medicine, and they gave me access to this other thing. Here, let me show you. Let me share my screen again. It's called VisualDX. And this is what it looks like. There's an app on it too, but basically what you do is that you type in what kind of skin condition it is, what it kind of looks like, and then it gives you all these differential diagnoses based on the description that you put in. And there's lots of pictures in there as well. So ask your school if they are willing to buy this for you, or it comes with a subscription in the residency that you go to. Highly recommend this. Or you can consult your dermatologist or your derm like co-residents and stuff like that. But I really like this particular app. It comes with the app, but it's also like, you know, on your computer. Next is, if you guys are in med school, you probably know of UpToDate. I highly recommend reading every single day, at least on one of your patients. So say like on the inpatient basis, you are learning about heart failure with reduced ejection fraction or something like that. And you look in your pocket medicine book to see how you manage them, but then you look further in UpToDate, like say at the end of the day, to see if you missed anything. So say heart failure treatment with heart failure with a reduced ejection fraction. There's lots of things on here that, you know, it's most up to date, I guess. It's like it's constantly being like updated. The key here is that if you sign in, like you have to sign in on a computer first to be able to access the app on your phone. So if you guys didn't know that you can do that, I think I had to teach some medical students that. But basically the app looks like, where'd it go? The app looks like this. So you can use it on your phone with data as long as you sign in with a computer first. Does that make sense? Okay, let's see. Look back at my Notion. And then other things, like if you are managing diabetes, like I would just go directly to like the American Academy of Endocrinology. If you're managing stuff with OBGYN, go to that particular subspecialty. Pediatrics, same thing, go to the American Academy of Pediatrics and look up some of their guidelines that they recommend specifically. Another cool app that that's for my son. Another cool app that I use specifically, it's more on an outpatient basis. I haven't seen most people do, like, maybe it's just my residency, but the internal medicine residents were not very good at pelvic exams, especially during inpatient. Like they would consult the OB to come and do a pelvic exam. So I just thought it was really funny. But if you're on an outpatient basis and you do like pap smears, I recommend this app, the ASCCP app. I don't know if you guys can see it, but it is called, hold on. Basically, it tells you what to do and how to manage screening pap smears, like what to do with the results, what to do for pre-colposcopy surveillance, what to do after evaluation of colposcopy biopsy, and so on and so forth. I would ask the OBs all the time, be like, oh yeah, like, do you just memorize? And they said no, because it's constantly being updated. And so you can look on UpToDate, but it just takes a lot longer. And so I personally just bought the app, which I really enjoy. And then USPSTF is another app that we use. It's good for intern year because it tells you all the recommendations from the United Task Force, basically, of like colonoscopy screenings and mammogram screenings and the different recommendation levels for each. Like, is this a grade B or whatever, CI recommendation? It's more so for studying for boards as well, because then there are questions on your board exam asking like, what level of recommendation is this? And so at least that you will be able to go through some of that. Another app that I use was just TrueLearn. I still think that you should use a question bank throughout your residency years to prep you for your board exam, just because the way that you learn medicine and the way you practice medicine may be a lot different than how the questions are actually asked in a board exam. And so what I did personally was I would do particular questions related to that block that I was on. So say I was on a nephrology rotation, then I would do nephrology question, all the question banks in there. I try to get it done beforehand because sometimes the preceptors like to pimp you on things that are in the question. So it kind of refreshes your memory a little bit. Same thing, cardiology, blah, 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 all that stuff. So I do have like a really old cardiology video explaining how I read EKGs, and I reference that from time to time too when I forget, but I think it's a really good basis video. I'm gonna see if I can find it for you guys. But I think it was just like how to read EKGs on my channel. Hold 1 second. How do I even search something on my own channel? Sorry, I'm so low tech, guys. Okay. So let me share my screen one more time. So this is the video that I'm talking about, medical school cardiology rotation ECG basics. And I go through like how to read EKGs, the pathophysiology of the EKG or ECG, whatever you like. But I think it's a good way to look at ECGs really quickly to see if there's anything unusual that you would need to consult cardiology for. So highly recommend this video. And then, sorry, I'm going back to Notion to see what else I missed to talk about. MDCalc. I don't know if you guys know MDCalc. It is a calculator to assess like risks. So say a person has, say a patient has AFib and you need to assess whether or not they need to be anticoagulated. So CHA2DS2-VASc score. It's also good to put all these scorings in your note to further emphasize or basically back up the decisions that you're making, right? So sepsis criteria, SIRS criteria, PERC rule, CHADS2-VASc score, sodium correlation for hyperglycemia, TIMI score, like lots of different like scorings on here, and you just click it and you answer the questions about the patient. And so I thought that was really helpful. And then a random thing that you probably might need to do, there's a lot of paperwork that goes on your intern year for some reason, and even throughout residency, I feel like. And so if you guys don't have something to scan your documents with, to send back into people, to sign things, I highly recommend CamScanner, CamScanner. I'm sorry you can't see these. So CamScanner is that one right there. And this one, you basically just take a picture of it and it resizes it, everything, and it looks really good. And you can send it to people via like PDF, email, and stuff. So those are all great apps that I use throughout my intern year and throughout my residency. All right. So let's move on to mindset. So this is really hard. I think that the hardest thing that you can do as a person, as a student and a resident, or a person in general, is controlling your mindset. You can't always control the environment that you're in. You're going to feel like you've lost so much control in residency just because, you know, people decide what rotations you're going to be on, and you barely get to decide when your vacations get to be. You get about 4 weeks of vacation a year, and that includes like your sick days. So you can look at it as in like, this sucks, I'm working 80 hours a week, like my life is miserable. Or you can look at it more from an infinite mindset and see that these are learning opportunities. This is going to shape who you are as a physician going forward. Things are, like it was really hard in the beginning, especially if you don't have like a group of residents that support you or attendings that support you. It can be really hard. And that's why I felt so lucky to be in the situation that I was in, because everyone was super supportive. I was still breastfeeding and I had a young child, and they all supported my decision to continue breastfeeding and gave me ample time. I just had to advocate for myself. So you can be pessimistic or you can be optimistic. I challenge you to, I feel like we all think negative thoughts, but I challenge you to try to look at things on a brighter perspective and just look at it from another view. Like every day I go into work and I think about the privilege that I have to be able to provide care for these patients. And I feel so honored that these patients trust me to provide this care for them. So like story time, I had probably one of the most worst experiences in my training during residency was when I was taking care of this patient, and I had just gotten handoff, and they were like, oh yeah, it's just this lump or this mass, like it's going to be fine. They're just going to send him home and follow up with a PCP. No big deal. You just have to wait for the official scan and then you can discharge them. But I'm going to go home because my shift is off. And so it's like, okay, sounds cool. And then the results came back as a possible cancer. And I was the one who had to tell this family that I just met that, you possibly have cancer, and, like, you possibly have cancer. Like, I don't know what else we can do. These are the next steps going forward. So it sucked. And after that, I was just like trying to debrief with my attending, and she was just like, I was like, so, how do you deal with this? Like, what can you do? And she told me, she's just like, yeah, you're just going to have to feel shitty for the rest of your life that you made this patient feel this way. And I was like, whoa, wow. Okay. And then another attending was standing right behind me, and she was just like, I look at it as in, I am grateful that I got to be the one to break it down to them, that I got to be the one to tell them about this experience or that their diagnosis, because I know that I come from a place of compassion and empathy, and I provided the most care I can for them. And so I feel proud about that, to bring some sort of relief to them. But yeah, like you can look at it like one way and look at it a totally different way. And so I encourage you to try to be positive, even though the situation might not always be positive, if that makes sense. And then your mentality of like that gunner mentality that you had in med school, please just drop it. Like that's not the mentality that you want during residency. It's all about teamwork, and not only like subspecialists, co-residents, but also like the MAs, the nurses, the staff, like everyone works together as a team to take care of this patient. And the only way that you're able to be better and provide the best patient care is that you work together as a team. I think eventually that people will learn that, what's that saying? It's like, if you want to go far, you go together. If you want to go fast, you go by yourself. And residency is a marathon. It's 3 plus 5+ years. And so you're not going to be able to sprint the whole time. You need to lean on each other. And so teach each other, provide opportunities for each other. If you can't do a procedure yourself, recommend your colleague. Or like if you've done multiple procedures before, teach your colleague. You don't have to, do that paracentesis all the time. Teaching is also a form of learning. And so I highly, highly recommend that you try not to be a gunner. It's very hard with the type A personalities, I feel like, but yeah. Secondly, your mindset. I feel that you have to be able to just think on your own. I feel like this is the time to think on your own. Attendings are going to tell you what to do sometimes, but I encourage you to ask why. I encourage you to develop your own plan and present your own plan before they say something about it. I guess that leads me into like dealing with failure, right? So I just want to say that residency is your time to make mistakes. If you ever going to make mistakes, like this is your time to do it, just because you have so many people looking over you. You have your senior resident looking over you. You have your attending looking over you. You have multiple people reading your notes and going over your plan with you, that this is the time to learn, right? And you're not going to be able to learn if you don't like go for it and you don't make mistakes. You need to build up that process in your brain to do it yourself. You have that safety net. And the best thing about this is like, no one expects you to be amazing. Like no one expects you to know every single thing, like come up with every single differential diagnosis, right? This is your time to just learn. And I think the hardest part about failure is when people look at it. Like, I think I was listening to Simon Sinek the other day, and he was saying how people compare failure, like he doesn't like the word failure, right? Because it's like the word cancer. You can have stage 4 lung cancer with a poor prognosis, or you can have BCC, which you just do like excisional, excise it and it's done. So it's not the same, right? And so when you say you failed, you automatically feel down upon yourself. It weighs upon you, on your mental health, on your physical health, and it pulls you down a really dark path. So instead of looking at it as like a failure, like cancer, I would say look at it more of just like, oh, I fell down and I'm going to pick myself up, or I fell down again, I'm going to pick myself up. Learning from your mistakes, continuing to learn. It's basically the growth versus fixed mindset. And they did a study before which showed that kids who learned in a fixed mindset were less likely to try more challenging things because they wanted to continue to look smart. Um, Whereas people with a growth mindset tend to gravitate more towards challenges and learning and enjoy the process of learning. And so those are the differences. Try to, you know, look at it from a growth mindset. And don't be scared of failure because it's never really failure. It's more of learning experiences. Okay. Um, and then I think that it's really important also to talk about loss, like dealing with loss. Um, since the time of COVID, we have been losing a lot more patients than usual, especially if you are in an ICU rotation. If you are ever during your OB rotation and you have lost births or mothers, it is super, super difficult. Sorry, I don't know why I'm like getting like all choked up. Um, so you have to find a way to be able to process these things. Residency, as I said, is very demanding. You have to work 80 hours a week at times. And so it's hard to say when you will have that time to, debrief. And so I highly recommend that you find your people, like whether that be your church, your spouse, your best friend, your dog, your children. I don't know, writing in a journal, you need to find a way to be able to process the information, like let it out and talk to somebody. I highly, highly, highly recommend counseling for anybody who has any, like, even if you feel like you're normal, people are going to benefit from counseling. Um, it's harder when you're a resident and these patients are yours. Like you feel responsible for everything that happens to them, and you feel hurt that you can't prevent sometimes the inevitable. And then dealing with the families and telling them and hurting with them, it's a very hard process. Um, and then losing people multiple times, like, like it's in a rapid process, it can be super hard. So talk to your attendings about it, the ones that you connect with. Talk to, I don't know, just talk to anybody. You need to let it out. Please don't bottle it in. Physician burnout is a real thing, and we lose physicians all the time due to suicide. And so if you need help, please reach out to any counseling service. So please don't stigmatize people who have mental health issues, because we need to talk about it more. Very high rate of like depression and anxiety with amongst physicians and other medical professionals like nurses, dentists, all that other stuff. So please support each other in that aspect. How to deal with mean attendings. I've had my fair share of mean attendings, I feel like. And I think that it's harder when you are an intern. And there's a fine line, right? There's a fine line between like cocky and confident. And so I think that you have to address it head on. If there's obviously like harassment, any of that sort, I would go directly to your program director and say something about it. But if it's like, if they're just like an ass, most of the time they're an ass to you is because they don't really know how to teach you. And that's how they were taught when they were going through residency. So what I recommend is setting the tone for things like this. So starting out my rotation, I would always ask my attendings, like, what are some of the things, or I would tell my attendings, these are some of the things that I want to learn during this rotation. These are my goals. And so after which I would always ask for like, I would ask for feedback. Generally, it's not just at the end of the rotation because it's hard. I sometimes would ask every single day or at least once a week and be like, how did I do this week? Or how was my presentation? How was my progress note? What do you think of my management about this? What do you think of my thought process about this? And ask for feedback. And then after you get feedback, you can, if you feel brave enough, you can also say like, I also want to give you feedback on how you're teaching me. At the end of the day, like, the attending is there to teach. And I want to say, like, I want to look at everybody in a positive light, but maybe the attending wants to be better as well. And so the only way that I'm going to be better personally as an attending, if I'm teaching medical students and residents, is if they give me feedback. If they tell me that I'm doing better, or it's something that I need to improve on. And so please tell your attendings, if you have the courage. I highly recommend please addressing these with the attending. And then the next day, like, say they give you some feedback, they tell you to go look up something, definitely go look it up and then present it to them the next day. Like, don't just wait for them to ask. Be like, oh, hey, like, you told me about this, I want to talk about it now, or during the break, or after you run through all the patient lists and stuff like that. That sounds like very impressive. And like, I would like, oh yeah, they actually listened to what I said. They went home and did their own research. They educated themselves. They're self-sufficient, and now they're here because they're dedicated. It says a lot about a student when you're able to do all those things. Okay, and then lastly, I want to talk about how to do more OMT in an inpatient basis, or like just in general. Specifically for me, because this is one of my passions, and I know a lot of you are worried about not being able to continue OMT later on in the future, especially if you're in a just MD program. And so OMT, for those of you who don't know, is an osteopathic manipulative treatment. OMM is osteopathic manipulative medicine. And what we do is we, use our hands to realign things that are out of place to, associate structure and function. We believe that if a structure is in line, then it helps with functionality of the body. What I have done this for on the inpatient basis is when patients have, say, pneumonia, you can do a little bit of rib bracing to help open up those ribs, helps with sympathetic and parasympathetic stimulation, just help them take deeper breaths to clear out all that mucus. Other things that we've done is like when people have shoulder pain or back pain, or just laying in the bed all day, we do manipulation to help with that as well. It's not just like on the outpatient basis, but you can do it on the inpatient basis to provide your patients like quality of care. Like, if you are able to do something that takes their pain away, why don't you do it, is basically what I'm asking. I've had, like, a cardiologist, Danielle, that I follow. She said that one time her patient was just been in the ICU for so long, and it was through the holidays, and so she brought in her set of like nail polish and stuff and gave the patient a manicure. Like, if someone could do like that, a manicure, like, why can't you do OMT? Like, you're providing care for a patient and making them feel better in that aspect. So I would just go for it. And no one has really precepted me. You've been through medical school, you've gone through the training, you know what you're doing. You just put it in your note, that's what you're doing, and go from there. All right, so those are some of the things that I wanted to talk about today. How to deal with intern year. It's going to be the most life-changing experience you go through, at least for me so far in my life. It's one of the most influential to how I am today, like the type of doctor I am today. I feel like it's made me a lot stronger. and better as a person, just residency in general. And so I don't want you to think that this is, like the worst years of your life. It can be like a beautiful experience. So I want to answer some of the questions you guys have here. And so let's see. Okay, so this says when you take step 3, was it during residency? How long did you study for? So step 1 happens after second year of med school. Step 2, I took third year, I think. Yes, I took it third year. And then step 3, I took it first year of residency. And it was during the first few months, I believe, of residency. And I studied not as much as I did for step 1 or step 2, to be brutally honest. I had a newborn child at that time, Wyatt. I was barely sleeping. And so step progressively gets easier. I don't know if it gets easier because I just know more clinical knowledge, or because the test itself is easier. I believe that the score that you need to pass is also lower. I'm not sure what the exact score is, but it gets easier. I didn't do any dedicated study time. I went through my question bank like 2 times, and then the wrong questions additional times. And then I did a couple practice tests, but that was about it. And then let's see. This is a good one. Would love to hear how you approach feeling like you don't know enough at the start. So as I said, you're not going to know enough. And I feel like even now, I feel like I don't know enough, and I'm constantly going to be learning. I think that the mentality that you have, or the persona that you have to give off to your attendings, is that I might not know enough and I might not know everything, but I'm here to learn. I'm willing to put in the work, and maybe even twice as much work, to be able to be the best that I can be. And I'm here to give my 100%. There's a lot of imposter syndrome because, you go from a med student where you don't have as much responsibility to a full-blown intern doctor, who my intern year, I took care of like 10 patients, had 10 or 10 people were on my list, had multiple discharges, multiple admits, and, taking care of all those people at the same time, feeling good enough, making sure that nobody died. I was like freaking out about giving people like aspirin or like ibuprofen. I was like, oh my God, are they going to bleed out? And so you question everything. Just know that this is because you care, and this is because you want to be a good doctor. And so I guess I would tell you guys my workflow during a normal day. So let's see. Normal inpatient workflow. All right, so normal inpatient workflow. I would get to my library around 5 o'clock in the morning. We have a set patient list. So if you're an intern, it depends on your hospital. Some people would have a cap, while other residencies do not. So a cap is when you have a capped number of patients, and then a no cap means you don't have a cap number of patients that you see. So as a senior resident, I didn't have a cap. As an intern resident, my cap was 10 patients. And so I would split it up amongst the other resident that was on my team. Usually we had 2 people. Sometimes if we were lucky, we had 3 people on the team, and we would just split the list. I would look through all my patients. Mondays are always the hardest, or whenever you start is always the hardest, because you have a new patient list and you have to know every single thing about the patient. their past medical history, their surgery, their family history, what has happened in the hospital. It's worse when they've been there for 40 days, but like know everything that's happened to them, all the workup that has been done, who's on the team, what medications they're on, what possible adverse reactions. And then you go through a plan. So a progress note is when you say, these are the diagnoses that the patient has, and this is the working things that we are going to do to be able to get the patient out. Usually if it's like pneumonia, you know how long they technically stay in the hospital for versus COPD exacerbation versus heart failure exacerbation and those things. Generally, people get better in a certain amount of time, and you can reassess that to make sure like, oh, this patient is healing and responding appropriately to our management, or they're responding a little bit slower. Like, why is that? Like, what are we missing? What's going wrong? And all that stuff. So I do that. I prep my progress notes, which means I put in all their diagnosis, I put in my plan, and then I penned it. Okay. And then I don't go see the patient because I think it's really rude to wake someone up at 5 o'clock in the morning, even though your attending wants you to see everybody before rounds. I just think that, you know, patients are already miserable in the hospital. They are getting woken up by beeping noises all the time and people drawing their blood. And so what you can do is, if you don't want to go read through all the notes from previous, I would just call in to the nurses and see like what happened overnight, tell them to give you like a soap or whatever, like handoff basically. So this is my patient, like how did they do? And is there anything that I'm missing? And so it's really nice just to like talk to the nurses, get to know the nurses, you know, because they're part of the team as well. After that, we had morning report, and then around 9 o'clock specifically for us, we met with the attending. We would go through the patient list one more time and then go see each patient. That is where you would describe the patient, go through your plan, the reasons for your plan and whatnot. They can agree or disagree. Your team members can also, you know, chime in. We did have a computer on wheels, and so any suggestions or changes that we did, I would put it into my note right then and there, order all the things that I need to order for the day, and then just sign the note, and that would like complete my note for that day. And then a whole admit would be something different. That would mean that you are going into the emergency department and doing the whole history and physical and stuff yourself. I personally like admissions better just because I like to start the plan. Progress notes are more like you are continuing someone else's plan and the trajectory that they're going. And so coming up with all those things yourself it's pretty fun. Okay. Let's see. This is a good question. Do you think specializing in FM is necessary, especially with the growing numbers of NPs and PAs doing a lot of primary care already? I obviously am biased. I think that family medicine is an amazing subspecialty. I think that NPs and PAs are a great part of a team, but it's a team, right? They're always going to need to be under a physician. I personally feel that there needs to be some sort of oversight. If there isn't oversight, there needs to be some form of credentialing to be able to say that this person, whatever training that they go to, is competent in providing the same quality care as a physician does. Like as a physician, we have to go through multiple board exams, go through rigorous training to be able to prove that we are capable of taking care of these patients. And so if an NP or PA wants to do that by themselves, I think that that's great, as long as they are able to prove that. Like I've just read so many, I know people argue that, so my issue is that NP programs are not standardized. And so there might be some amazing programs, there might be amazing NPs, but at the same time, there are also horrible NPs who don't go through as much training, or their program is just like, you just give us money and then you find your rotations on your own. You have to find a doctor to shadow on your own, and they don't help you set that up at all. And so it's very inconsistent. And so like I've read, I know people will argue that, their studies have shown that NPs and PAs provide the same quality care and there's no patient harm that comes from it. But there are those near misses that physicians have like caught on. Like, for example, there was this physician who said like she's been working with her best NP for over 10 years in hospital patient basis, and the NP was discharging a pyelonephritis, looks at the sensitivities of the antibiotics and sends them home on nitrofurantoin. And then for those, or macrobid. And so for those of you who understand medicine, know that this is not the right management for pyelonephritis, even though nitrofurantoin is on the sensitivities and it's one of the cheaper medications to use and it's good orally. And the reason why is because nitrofurantoin is a medication that concentrates in the bladder. It does not concentrate in the kidneys where the infection is. And so even though, it's sensitive, we shouldn't use that medication and should be something else like Cipro. And so things like that, like, yes, it's a near miss, but it's a miss, right? If there wasn't checks and balances, then that patient could have gone home and become more sick and then come back in. There's lots of little things like this, little nuances like this that happens in medicine that is not necessarily always reported. And so I think that as long as you're able to prove competency, it's totally fine. And so that being said, there's always going to be a need for a family medicine physician. I call it like we're the great quarterbacks. We know when to pass and we know when to run and we know what to do because we see the whole picture. I personally did not have issues with the job market. Like I still was able to get multiple job offers. I was still able to negotiate my salary. I still do plenty of procedures. I'm not in fear of my job, basically. Like I still have really good job security. So if you want to go into family medicine or internal medicine or whatnot, please go for it. Do not be worried. Like the job market is still there for you. So let's see. And compared to other than let's see, interesting question here. As a general scope, does family medicine have higher quantity of continuing education compared to other specialties like orthopedic surgeons and ophthalmologists? How many hours a day on average did you study? So in med school, I studied every day. Like I studied from the time I woke up until the time I went to sleep, besides like eating and working out. During residency, like I feel like it depends on the rotation. So 80 hours a week for inpatient rotations, you are constantly working and reading and studying. And after that, maybe a couple hours at home where I would do practice questions or read journal articles and things like that. But I did have a family. I don't know what the difference is in ophthalmology, orthopedic surgeons. Like I feel like orthopedic or any sort of surgery has more call, I would say. They would have more trauma and they would have to do like the schedule is more inconsistent, I would say, because you don't know when people would need surgery if they're in a trauma. And so you have to be on call for those things. I don't know if the studying is any different. There's a lot of things that you need to study in family medicine because there's such a wide scope. continuing medical education. Everybody has to have 50 hours, I believe, every year after they graduate residency. So that means like going to conferences, going, doing hands-on training. You choose what that is. I know I had an attending on the inpatient basis who went to like more ultrasound, point of care ultrasound trainings or procedural trainings that she wanted to do. So she did all that stuff. So yeah. And then let's see. All right, so let's do a few more questions and then we'll call it a day. And then if you guys like things like this, like just let me know. Comment in the comment section below to tell me, you know, what I should talk about next, because I love hanging out with you guys, and maybe I can bring in more people to get their opinions and stuff like that. So we'll see. Did I do research in residency? How feasible is it with a large workload? So I think you can. I was in the works of doing, I did poster presentations because it was required of me. There's other side projects that you're required to do, which is like present at a national conference and lots of other things. But as for research, I was working on this research where it was a treatment with OMT for patients in labor. Are we able to decrease the duration of which they went through labor, and if OMT helped with decreasing pain by needing less pain medication. And so we were designing that study and doing all that, putting it all together. It took a lot of work, but you can also recruit other people like medical students and other residents to help you. So it is always possible, but as I said, it does take some more of your time. It's easier if you extend it throughout your residency, like all 3 years, to work on something, or if that's something that you're interested in. For me, it is hard to do something like that because it's not something that I'm like I know I want there to be more research on OMT, but I hate doing the grunt work. Like I love reading the articles. I love other people designing the studies and going through with all that. There's just so much like bureaucracy and all that stuff behind it that it's really difficult for me personally to get into it. But if research is your thing, go for it. Like people love that you have research, probably because the institution looks better if you get published, but that's just my 2 cents. Okay. All right. I think that is all we are going to talk about today. Let me know if you guys found this useful. It would really help me out if you guys give me a thumbs up or follow on this channel. It's free for you and it totally helped me out. So just to spread this channel to more viewers. So yeah, love hanging out with you guys. Let me know if you like this. I will do more of it in the future. Let me know if you like StreamYard, if you like that I'm able to share my screen with you guys. And then we can go from there. All right. Have a good weekend, everybody. Good luck on intern year. Good luck on medical school. Good luck in life. I hope you guys spread positivity and kindness. So I'll see you guys again next week.